Good evening, everybody, and welcome to the fifth edition of our Cannabis Thinking Talks. My name is Alex Lucena, and I am an associate partner to the Green Hub and head of innovation. So this time around, we have a very special guest with us that I'll have the pleasure to introduce in a few minutes. But before I do that, I'll just go around the room very quickly. We have a fantastic lineup of people here to interview and to chat with Professor Mishula this evening. So first of all, I'd like to welcome for the first time in our Cannabis Thinking Talks, one of Brazil's top scientists, researcher, professor from the Federal University of Rio de Janeiro, Stevens Reis. Thanks so much for being with us this evening. It's a pleasure. Also, for the first time, and I mean, also very honored to have Edson Cordeiro from Merck Life Science, the German multinational company. Edson is a big partner of the Green Hub. He is the global strategy leader for industrial lab testing and cannabis testing within Merck. Edson, pleasure. Thanks a lot. To taking the time to be with us tonight. And of course, Daniel Jordan, founder of Portal Sechat, main reference in news, in the Brazilian cannabis news. Daniel, again, always good to have you with us.
Thank you.
And last but not least, my associate partner, Marcelo Greco, founder of the Green Hub, and also one of the most thoughtful people within the cannabis Brazilian industry. So, like I usually say, with no further ado, our guest tonight is, well, he's known to be the father of the cannabis research, or, you know, I was just chatting before we started. We consider him to be the Pele of the cannabis industry for us in Brazil, Dr. Rafael Mechoulam. Dr. Rafael Mechoulam from Hebrew University of Jerusalem. It's a great pleasure. It's an honor having you with us, Professor. Welcome to Cannabis Thinking Talks. Welcome to Brazil, which is a country that we know you have many friends and that you have a lot of to tell us. We'd love to learn from you tonight. Thank you very much.
Well, thank you for the introduction. It's a pleasure. I've collaborated with many scientists in Brazil over many years, maybe 30 or 40 years, and it has always been a pleasure. I was in Brazil many years ago. Unfortunately, now this is impossible, so I'll be delighted to tell you about our own work, our research in the past, our research at the present.
Excellent, Professor. So I'll be circling the questions, and after your response, we have time for to talk a little bit about what you just said, and we'll keep it going that way. We have, give or take, about an hour. Okay. Good for you?
Go ahead.
Okay. Let me start with Stevens. Like I said, researcher from the Federal University of Rio, and somebody that we learn a lot on a daily basis when it comes to science. Stevens, please kick it off.
Thank you, Alex. So it's my great pleasure to be here with Dr. Mechoulam. And my first question couldn't be other one, but related to the entourage effect. I'd like to know from Dr. Mechoulam if, like, based on the recent advances in the analytical chemistry, if he thinks that would be possible to discover the exact combination of the cannabinoids that would have a certain effect. In other words, would it be possible to dissect the entourage effect? And as a complementary question, I'd like to know if he believes that the entourage effect could go beyond the CB receptors. I'm saying that because we know that like terpenoids, they do not necessarily modify the effect of the cannabinoid agonists in the receptors. So maybe the entourage effect goes beyond the signaling through the CB receptors.
Well, the entourage effect is a strange one. Normally, in science, in medicine, we prefer to have a pure compound so that we can go ahead knowing the exact dose and the exact effects of a single compound. And this is what we have been doing, and of course, most pharmaceutical companies do that for obvious reasons. Now, many years ago, we knew that people prefer to use the total extract rather than the pure compound, cannabidiol, THC. So we looked at the possibility that the total extract will differ in its activity than the pure compound. And yes, we found that in certain cases, not in all of them, but in certain cases, the total extract may be better, at least from the point of view of the person that's taking it, may be better than the pure compound. And we call this the entourage effect. And unfortunately, there has not been much research on the entourage effect. We published a paper or two on that, but we are going into many different directions. And I hope that people will be looking at the entourage effect. So it is very difficult to answer your question in detail because there is no information. There is not enough information of what's going on. We know that some compounds in the extract may have specific activities. One compound binds to one of the receptors and activates it, to the CB2 receptor, the receptor that doesn't cause the well-known marijuana effects. It's a receptor, the CB2 receptor is usually believed to be a protective receptor, which does not cause any side effects and does not cause the effects that are generally known to be due to THC, which binds to both one receptor and two receptors. And the one receptor causes the psychological effect, the cannabinoid effect, the marijuana effect. The other one does not. And there are compounds, terpenes, that bind only to the CB2 receptor. So this means that if somebody extracts the material, and there are compounds that act only in the CB2, together with THC and together with CBD, there will be better effects. The same is true for some of the terpenes. Unfortunately, as I said, we don't know enough, and I've been trying to convince my colleagues, particularly people that work in the clinic, to try to compare in the clinic the pure compound with extracts that have a good analysis. Because in many cases, people say, I took medical marijuana. Well, that doesn't mean much. What does medical marijuana mean? I mean, we have to know not just the concentrations of the specific cannabinoids, THC, cannabidiol, namely CBD. We have to know some of the other compounds as well. And unfortunately, data on the entourage effect is not available. And I strongly suggest that clinicians, chemists, biologists should look at. Now, the second question was, is there an entourage effect in many other compounds? Well, obviously with synthetic compounds, it's not relevant. But with natural products, it's possible that we have entourage effects. And entourage effects in this case can be, as it is with cannabis actually, that there are compounds that add to the activity, but there are also compounds that block the enzyme that breaks down the active material. So it is quite possible that we have compounds of this type. And indeed, this is what people should be looking at. But to the best of my knowledge, at the moment, very, very few people are doing this. Sorry, I couldn't be more positive, but that's where we stand.
That's great. Thank you.
Every time around, please, people, be free to step in and let's keep as a chat. Edson, would you like to take it for your second round, please?
Yes, sure. First of all, thank you again, Professor Michelin, for the opportunity. My question is going to be not deep scientific like this, but my question is much more about the pace of the development of the medical research and the clinical trials with cannabis. I think more than 35 years ago, I think almost 40 years ago, you conducted a study which was carried out here in São Paulo with the patients treating patients with cannabis, epilepsy, patients with epilepsy with cannabis. And showing some results like the reduction of the seizures and other things. It was almost 40 years ago, and if I'm not wrong, there was no other study published on this since then. So using your phrase when you published your study, introduction of the cannabinoids as a therapeutic agents, you put one phrase at the top of your study. It was, are we missing something? I know in that time you were referring to other things. After this, your team come up with the endocannabinoid systems and this anandamide and others. I would say the environment was other. For my question is, are we missing something or a lot of things in terms of clinical trials and medical researches in cannabis?
Well, thank you. Well, it can be a short one, my answer, and the answer is yes. Or it can be a little bit longer, and I can talk for about 2 hours on what we are missing. So I'll try to say a few words. You referred to the joint work, the Brazilian group, my group, and epilepsy. I mean, at some point I was sitting with Carlini at a meeting and we were discussing the possibility of cannabinoids in epilepsy. This has been known for many, many years. I mean, it's the fact that cannabis works on epilepsy has been known in the popular literature for ages. There is some information of the 15th century on that. But there was no modern work. And some modern work in animals was being done by several groups. So Carlini and I decided that maybe we should go ahead and try to have a clinical trial. So we isolated a huge amount of cannabidiol. We ultimately sent to Brazil about half a kilo, 500 grams of cannabidiol, which we isolated from hashish. Incidentally, the hashish I got from the police. I'm on good terms with the police. I go there and I have to sign that it's for scientific reasons. They give me hashish, and we isolated from hashish almost half a kilo of cannabidiol. A lot of work.
Accidentally, right, Professor?
Sorry?
That was accidental.
Yeah.
Okay.
And so originally, Carlini's work was on animals and mice. He had an excellent model for epilepsy, and he found that, yes, as it was in the literature, and there was some also modern literature, definitely cannabidiol works on epilepsy. So the next step was to do it in the clinic. And for the clinic, he needed huge amounts of cannabidiol, and that's why we had to isolate so much material. And the effects, and he did a 15-person trial. Half of them got a placebo, half of them got a cannabidiol. Originally, he gave them 200 milligrams. In one case, he gave a little bit more. And we were delighted that the effects were there. And these were patients that nothing was helping them anymore. These were patients that the known drugs did not act on them. And it turned out that about 8 patients were getting the drug. There were about 7 patients that were getting the placebo. Of the 8 patients that were getting the drug, 4 had much less attacks. The 3 had less, but not so prominent, and only 1 was not affected. So here was something that showed, we believed so, that maybe there should be a larger clinical trials. I mean, as academics, we cannot do 300 patients or 500 patients as companies do. We did it on 15 patients, and we believed, Kaleni and I, that now the field is open for a major trial, as there are a lot of people that are not well treated with the drugs that were existing at that time. Well, unfortunately, as it happened, and it still happens today, and I have to say a few words about it, although we published our paper, joint paper in 1980, nothing happened for 35 years. The paper was there, maybe people read it, but nothing happened. Now, at that point, families in the US they heard about the paper, they heard about the ability of cannabis to, especially cannabis that contains high levels of cannabidiol, can affect epilepsy, and they started using it. And public pressure in the US allowed the company, a British company, to do a large clinical trial. And the large clinical trial, which was done very well, confirmed completely our results. We had done the original trial on adult patients. They did it on children, and they found that yes, most definitely, cannabidiol worked. And so they did a clinical trial. Cannabidiol was approved for 2 types of epilepsy. Epilepsy is not one disease. There are many diseases that cause epilepsy. And so we have 2 types of epilepsy, pediatric epilepsy, which have been confirmed. And over the last 2 or 3 weeks, I believe, a 3rd type of epilepsy was approved. And it works in about 60% of the children that are being treated. In Israel, we have been administering cannabidiol for almost 2 or 3 years, and the effects are very positive. About 60%, 70% of the children that nothing else was helping them are being treated, and yes, the results are positive. Now, so far, so good, but there are a lot of diseases in which we see a lot of positive results, whether it's in the clinic or whether it's only in animals, and yet we have not gone ahead. And it's a pity because many of these diseases can be treated. For example, I'll give maybe 2 examples that are okay at the moment. Okay, I'll give 2 examples. One is diabetes type 1. There are 2 types of diabetes. Diabetes type 1, in which we did preclinical trials in animals that have the mechanism there is exact as in the humans. And we found that in diabetes type 1, cannabidiol is an excellent drug. Normally in this type of animals, this type of mice, they get diabetes and die very young. We gave these animals cannabidiol, and those animals that received the cannabidiol went on and lived much, much longer than those that didn't. So there is something there. Cannabidiol definitely acts. We know, or we believe we know, something about the mechanism. The mechanism exactly the same as in humans in this particular case. It's not always the case in animal trials, but in this particular case, we saw that the mechanism is the same. So there should be a clinical trial with diabetes type 1. There is a need for additional drugs. Not all patients with diabetes type 1 are well treated today. Here we have a compound, cannabidiol, which is excellent in animals, so there should be a clinical trial. And yet there isn't. Why? It's a question of legal problems, money problems, and so on. There is no patent on that. And of course, companies have problems involving doing clinical trials with compounds on which they have no patent. So here we have something that can help. And this is just one example. There are quite a few. I'll give a second example, which is slightly different. A German professor, Professor Leveke, who is now in Australia, I believe, did a 2 or 3 years clinical trial with cannabidiol in schizophrenia. Now, schizophrenia is a complicated disease, and not all patients are well treated with the drugs we have. Fortunately, most patients are affected positively with the drugs we have, but some are not. And most of the drugs that are being used in the clinic in schizophrenia have side effects, serious side effects, and many patients prefer not to take them. Cannabidiol does not have side effects, at least not major ones, and it's not toxic. So Leveke tried cannabidiol in schizophrenia patients. He's a psychiatrist, and the results were published, and the effects were positive, very positive. There has been a second trial with cannabidiol in schizophrenia, and that was published too by another group. A third group found that at the different, at lower levels, cannabidiol does not act, or at least does not act as well as Leveke said at the beginning. So here we have in our hands published that cannabidiol seems to be a very, very promising drug in schizophrenia, and yet, although Leveke published his work about 6 or 7 years ago, nothing has happened. We can help, I mean, we, the scientists, can help patients, and nothing is happening. So I can give you quite a few other examples. So we have a situation, there is a lot of preclinical work and a large number of diseases, but unfortunately, very, very few are going into the clinic. And this has to be, this is to be regretted very much. Now, one way of solving it is to prepare cannabidiol derivatives, novel cannabidiol derivatives, which are even more potent than cannabidiol itself. There will be patents, or there are patents on these compounds, and then the companies can go ahead and use these compounds in the clinic and test them. And we have, for example, one compound which is cannabidiol acid, methyl ester, which is being developed by a company. So we hope that this compound and many others will be developed, and we shall see derivatives of cannabidiol in a large number of clinical situations.
Very interesting, Professor. Anybody want to put in a comment? Steven, Edsel?
I just would like to thank you and say, summarizing, we are missing a lot of things.
Yes.
We are missing, and it's a pity. It's really a pity, because cannabidiol, as an example, is an excellent drug in the sense that it causes essentially no side effect, and it has no toxicity. So if modern clinical trials are done with cannabidiol or derivatives of cannabidiol, we shall have a new type of drugs for quite a few additional diseases.
Thank you, Professor.
Yeah, Alex, may I add one quick comment here? Maybe it would be more like a follow-up question, is that because
Sure.
Professor Meshulam mentioned very briefly about this new compound that he just discovered, that we can also name it as MPM-301. So Professor Meshulam, if you could talk a little bit more about this derivative that you just discovered.
Well,
interesting.
You see, THC and cannabidiol are not natural products, actually. Tetrahydrocannabinol, THC, is not made by the plant. The plant prepares a precursor, an acid. The same is true for cannabidiol. The plant makes a cannabidiolic acid. These two compounds, THC acid, CBD acid, break down into THC and into CBD. But while there has been a lot of work on THC and there has been a lot of work on CBD, there is a very, very little work on the precursors, on the acids. And the reason is that these acids are not stable. So we decided a few years ago to stabilize these compounds. And it's possible to do that by a very simple chemical reaction. And we have cannabidiolic acid, methyl ester, a simple derivative of cannabidiolic acid. And this was tested by friends in the UK, Roger Pertwee, and it was tested in Canada, again by colleagues. As I said before, quite a bit of my work is done in collaboration with colleagues. We drink a lot of coffee together, and Brazilian coffee. And yes, it seems to be a very potent compound. It was found to lower anxiety, and by another group to be a potent anti-pain compound. So here we have a compound which seems to be even more active than CBD itself. So a company is developing this compound under the name EPM-301, and they're working mostly on inflammation, I believe. And chances are that it will become a drug because it's not toxic and does not have side effects like cannabidiol, a little bit more active than cannabidiol. So here we have a development, and I sincerely hope that this will be possible. Now, we have published additional derivative. We took, for example, cannabidiol and put a fluorine atom on the cannabidiol molecule. Now, why a fluorine atom? Cannabinoids are lipid-soluble compounds, like steroids. And for many years, companies have made steroids with a fluorine compound, with a fluorine atom on the molecule. This has been going on for 20, 30, maybe more years. So on this basis, we said, well, here we have a lipid-soluble compound. Let's try and put a fluorine atom. And yes, we published that, and the compound, the fluorine-derived cannabidiol, in many respects is more active than cannabidiol itself. So here, again, a company, I hope they are developing it. Here we have a derivative which is more active than cannabidiol, and the company has patents, and therefore it can develop it. Hopefully, this type of compounds will make possible the use of cannabidiol type compounds in the clinic, which is, of course, what has happened with many natural products. Penicillin. You cannot buy penicillin at the drugstore. You can buy derivatives of penicillin, or corticosteroids. You can, well, nobody uses pure cortisone as a drug. People use derivatives of cortisone as drugs. It's a minor market, probably 10 billion or probably $15 billion of compounds of this type. So I strongly believe that derivatives of cannabidiol will enter the market and will help a lot of people in many different fields.
Excellent. Daniel, it's your turn.
Okay. Professor Mechoulam, welcome to Brazil. It's an honor to participate in this conversation and have the opportunity to speak, as Alex mentioned before, with the pale of medicinal cannabis. You always speak in your classes not to forget THC. We have seen many countries, including Brazil, an advance in cannabidiol policy and regulations, and a demonization of THC. How do you see this THC prejudice? And from the science point of view, what is your advice to regulators regarding the THC?
Well, THC is the main psychoactive compound in cannabis, and it causes effects which are being used for recreational purposes. But as a medicinal agent, THC, in my view, is less important than CBD because of the psychoactivity. I mean, a person that has pain does not want to have the psychoactive effects. He wants to go to work, wants to go to school. And at that point, THC is less important than CBD. On the other hand, there are many drugs that cause side effects. So one has to work with THC as a medicinal agent carefully, not use high levels of THC, because the low levels of THC have very positive effects. And for example, we did some clinical work on post-trauma, and we gave to post-trauma patients THC at low levels, 3 times a day. They didn't get high. And we found that, yes, it affects the post-trauma patients, in particular in sleep. Post-trauma patients, for example, are afraid to go to sleep because they wake up in the middle of the night recalling whatever caused the trauma, whether it was a soldier that somebody died next to him, or whether that was a young woman that was raped and got a post-trauma because of that, things of that sort. And people that have post-trauma are afraid to go to sleep because they wake up the middle of the night with a trauma again. THC definitely helped them sleep. Very important, very important. There, of course, THC is a drug under the name Marinol, which is an approved drug, not a major drug. And it is used to prevent the side effects of chemotherapy. In some of the drugs that are given for chemotherapy cause side effects, and THC is definitely a good drug for that, but it is not a major drug. And I don't believe that THC can be compared to CBD because of its side effects. Now, if we're speaking of drugs, if you at a later point, or now, I can speak of the natural products that we make, that our brain makes, and THC actually mimics the effects of these compounds, like anandamide. But do you want me to speak about that now or later?
Oh, up to you, Professor. I'm very interested here and curious.
Okay, I'll go ahead. You see, THC acts on 2 receptors, on CB1 and on CB2. Now, these receptors are present in the animal body, in the animal brain. We have CB1 and CB2. Now, we don't have receptors because there is a plant out there. We have receptors in our body, in our brain, because we, as animals, we have compounds that activate these receptors. There is a dopamine receptors, and dopamine affects them. There is a serotonin receptor, serotonin acts on them. Now there is a cannabinoid receptor. So we said, okay, if there is a cannabinoid receptor, there should be a natural cannabinoid, endogenous cannabinoid, which activates these receptors. So quite a few years ago, we went ahead, again in collaboration, several groups, we looking for the compounds that activate these receptors. And way back in 1992, we found anandamide, a compound which acts on both CB1 and CB2. THC mimics the effect of anandamide. Chemically, they're completely different. THC has a certain structure. Anandamide has another structure, completely different. It is a derivative of a fatty acid with amino acid derivative. So here we have a compound that our brain makes, and there is THC does all the things that this particular compound, anandamide, makes. But there is one difference. THC stays in our body for a longer time than anandamide. Anandamide is made by our body, by our brain, when and where needed. We don't have large amounts of that. It's made when and where needed. It acts and then the body breaks it down. So the side effects of anandamide are not there. Now here we have something that I've never understood. It is not toxic, it does not cause major side effects. Anandamide has never been administered to a human being in any experiment. Not that it has not been developed as a drug, it's even far away, but it has never been administered. Now, if we go back a few years ago, 100 years ago, when insulin was discovered, insulin has an important task in diabetes in our body. It was tested, and within a year or two, it became a drug, an excellent drug for diabetes. Anandamide, which also is not toxic, does not cause side effects, it has never been administered to a human, although it is a natural product that we make, that our brain makes. And the reason for that is there is no patent, it costs a lot of money to do it, and so on and so forth. The same is true for a second compound, which also acts in the same way. It is called 2-AG, again, derivative, it's closely related to anandamide. So here we have something, let's say, even outrageous. We have a natural product, which is of extreme importance, and yet it has not been tested in humans, although it has been now known for 25 years. And these compounds, namely the receptor, the natural product, anandamide, the enzymes that make the natural product, and the enzymes that break it down, they are known today as the endocannabinoid system, a major biological system, biochemical system. As a matter of fact, scientists at NIH published a review and mentioned, amongst many other things, that the endocannabinoid system is probably involved in almost all human diseases. So here we have an endocannabinoid system which is involved in so many diseases and yet not tested in humans. I don't understand that, but there we are.
Wow. Marcelo, please step in. I love when you're speaking. Go ahead, Marcelo.
Yes. Good evening, Professor. Again, a big honor, a huge honor to be speaking with you. I'm a big fan of yours. And my question is it's simple, but at the same time, really important for us here in Brazil to know. Professor, what do you consider the major challenges for the future of cannabinoid research?
Well, already mentioned, we know quite a bit on the basic science. We know quite a bit on THC, we know quite a bit on CBD, we know quite a bit on anandamide and on 2-AG, the endogenous cannabinoids. So chances are the derivatives of cannabidiol, derivatives of anandamide, of 2-AG, will become drugs. Like many other neurotransmitters, there are many drugs based on neurotransmitters. Chances are that derivatives of anandamide will become drugs. But there is also something else. Actually, when we speak of cannabis, most people think only of the plant. But here we have three phases of cannabinoid research. The work on the plant and the cannabinoid, THC, CBD, cannabigerol, and so on. We have not spoken about cannabigerol and so on. Then the second phase is the endogenous compounds, anandamide and so on. But there is also a third phase. And the third phase is based on anandamide. Now, as I mentioned previously, anandamide is a fatty acid bound to ethanolamine, a derivative of amino acid. In our body, we have about 20 fatty acids, about 20 amino acids. So that our body, the animal body, uses the same mechanism to put these together, not only to make anandamide, but also to make a long list of additional compounds. So in our body, we have a large number of compounds that are parallel to anandamide. Compounds that are fatty acid bound to amino acid. Now, our body makes these compounds. Now, I can't believe that our body in evolution will make compounds because it has nothing else to do. Our body doesn't make it just for fun. It makes it for a certain reason. So we went ahead looking at other diseases that are affected by anandamide-like compounds. And I think this is the third phase of cannabinoid research. And yes, there are many disease situations in which these compounds, anandamide-like compounds, are very effective. We started 10, 12 years ago, and we looked for vasoconstriction. Now, when there is brain damage or brain, the brain is damaged, one sees vasoconstriction, the blood vessels constrict. And this is not healthy because then not enough blood goes where it should go. And we found a compound which is closely related to anandamide, which blocks the vasoconstriction. And we published that. Then with another colleague that works on bones, we went ahead looking for anandamide-like compound that may work on osteoporosis. Now, osteoporosis is a major, major disease. When people are young, their bones are being broken at a certain rate, but at the same time, the body builds the bones. So there is an equilibrium between building the bone and breaking the bone. But after a certain age, and this has been researched very well in women, after a certain age, the breaking of the bone is faster than the building of the bone. So everybody should have osteoporosis. Well, this is not true. The body blocks this effect. So we looked at that with Professor Itai Bab, and we found a compound, an anandamide-like compound, or if you wish, an endocannabinoid-like compound, which blocks osteoporosis. And there we are. Here we have another way of, we see another way that the body acts and blocks disease situations, an anandamide-like compound. And over the last 5 or 6 years, we have been working on addiction. Why? How does addiction bind to all these things? You see, addiction for our body is a disease. For many years, people thought addiction is something just has to do with our emotions, if you wish. No, addiction is a disease. And if there is a disease, the body will try to fight the disease. So we went ahead looking for a mechanism that our body uses to fight addiction. And again, we, in this case, as I mentioned before, is a major group of one working in the US, one working in Canada, one working in Italy, and my group. And we indeed found a compound that is present in a certain part of the brain which blocks nicotine addiction. If we take this compound and look at models of addiction, and there are a lot of models, I wouldn't go into all these things, in all these details, this compound blocks nicotine addiction. So this may be the reason why many people that smoke do not get addicted, because most of the work on addiction has been done on people that get addicted. There is almost no work on people that do not get addicted. Why don't they get addicted? The reason is they seem to be making this compound and it blocks the nicotine addiction. And here we also found and published work that was done mostly by the Canadian part of our full group, if you wish, major group, that this particular compound blocks the withdrawal symptoms of nicotine addiction and also blocks the withdrawal symptoms of opiate addiction, of heroin. Somebody is addicted to heroin and does not get heroin, he can go in, he can get terrible withdrawal symptoms. And many of the people that are addicted to opiates or heroin will do anything not to have that withdrawal symptom. Here we have a compound that the body makes that blocks nicotine and withdrawal and heroin withdrawal. And these compounds are anandamide-like. They're endocannabinoids, if you wish. So we're speaking of the endocannabinoid system, not just as the plant, but we have the three phases. We have the plant, we have the anandamide that our body makes, and we have the many, many compounds, probably about 60 or 70 compounds that our body makes, and they're anandamide-like compounds, and many of them are very active. Most have not been looked into thoroughly. So I believe that in the next decade, many groups will find that these compounds are of extreme importance, that they fight many disease states, and I hope that we shall be able to add a little bit to this research.
Wow, such rich information for researchers to start opening their heads and so many things that they can start working. Thank you very much. This was really rich information for us here.
Yes, I'll hand it back to Stevens for the final questions. We're pretty much approaching the end of the hour. This is fantastic, Professor, because I don't know if you know this, Brazil is one of the countries around the world that has most doctors. We have about 500,000 doctors in our country, but only, as far as we know, about 1,000 are prescribing. So there's a need of education. So doctors that are close to the patients can be comfortable and have knowledge enough to prescribe. So the more science we add into the conversation, the more we're getting advocates that will be talking about the endocannabinoid system and everything that it can do in positive for us human beings.
And not only doctors, but scientists. We need more scientists in this subject too. So this is really, really rich information that we can bring new scientists to the subject, to this ecosystem.
Yes.
Well, physicians don't get information at the medical school on the endocannabinoid system. It's a new system, and the information doesn't get to most physicians. Now, in order to help to change this situation, our Ministry of Health, and I'm a little bit involved with them, I consult with them, I'm head of the research committee there. The Ministry of Health organized courses for physicians, just physicians, on the cannabinoid system. And they had to pass a certain course, pass an exam, and then they are allowed to prescribe cannabis, the various types of cannabis that are prescribed in this country. Only a physician that has passed a course like that can do it. But they are better informed, and therefore they have the background knowledge. So Israel, which is a small country, we are less than 10 million, we have about 70,000 patients that get various types of medical cannabis. A lot of THC, a little bit of CBD, or all kinds, depends on the disease. And these have been prescribed by physicians that have taken those courses. So this is where we stand. It may be a reasonable way of advancing the field by teaching the physicians who have an excellent background in many other fields, but not in this field. And I expect that this is what's going to happen in many other countries. Have courses by the authorities, by the ministry and so on, and teach physicians about the cannabinoid system, and then these physicians will be able to administer, to prescribe cannabis. Cannabis now is prescribed only in pharmacies. One cannot go and buy it outside. It has to be in a pharmacy, and the pharmacists have to know a little bit about it. So here we have a situation that it's changing all the time, and we hope that this is the way to do it. But there are many other ways.
Correct. Stevens, back to you, and after you, we'll be circling around for the wrap-up.
Okay, it's a short question. You mentioned, Dr. Meshulam, about the importance of the endocannabinoid system for basically almost of the disease. I'd like to know your opinion about the importance of the endocannabinoid system for aging and longevity. Can we think that maybe in the future we would have like the activation of endocannabinoid system as some kind of hormone replacement therapy?
Well, there is a little bit of work on aging, but aging is not a simple problem. We have just any system in our body starts aging. And I know that well because I'm 90 years old, and I know that, my bones change and my everything that I have changes. I hope that my brain doesn't change too much, but that will happen. So is the endocannabinoid system involved? It seems to be involved in aging, definitely, but we don't know enough. Do we have different levels of endocannabinoids, the age of 20 and the age of 90? We don't know exactly because it's difficult to do that in humans, and we can do it in animals, but then we are not mice. So we know about mice, but we don't know about humans. There are definitely differences, and there are also differences that have to do with emotions. And so there is a lot to work, a lot to know about the the endocannabinoid system in all these fields, not just aging, but also emotions, also differences in personalities, and so on. So this system seems to be of extreme importance because there are so many compounds in our body that are part of this system. Again, I wish we knew a little bit more about aging.
Well, Professor, first of all, congratulations for, 90 years old and being able to be in your position. I mean, so much knowledge. I hope you live another many, many years with quality, because I guess this is where we want to be, hopefully. Us here in this room will come close to that.
Thank you very much. I really appreciate it. It was a pleasure talking to you, as I talked to many of my friends in South America, particularly in Brazil, and I'm going to be in touch today or maybe tomorrow with Professor Kripa, to find out how his work on the present disease works. You see, there is a problem there, because the first phase is an attack by the virus. But the second phase of the corona disease involves very high levels of cytokines that are produced. And it seems that much of the damage that's done the corona disease is due to the very high levels of cytokines. And cannabidiol is known to lower the production of cytokines. So we discussed that, and he's trying on a large scale to see whether cannabidiol, when given probably at the second stage, will help with the disease. Maybe.
Ed, so let's circle around just for I know everybody wants to say, not goodbye, but farewell to Professor Mashula.
So, Professor, I could stay here for a day, listen to you. It's really nice. You make the things, as we used to say in Brazil, you make the things, you speak in Portuguese. You make it easy. So thank you very much again. I think now it's time for you to rest a little bit and maybe have, I don't know, but maybe have a piece of cake from Delias. And shalom, Professor. Thank you.
Many thanks and all the best. Bye-bye.
The story about the cake, we'll have to talk about that in our next talk. It's very famous. Marcelo, go ahead.
No, I would like to thank Professor for being with us, and it was so rich, such rich information. I could be here for 2 more hours listening and learning, and I hope we can do this again. Thank you very much for your time, Professor.
Daniel, go ahead.
Thank you very much for sharing with us your knowledge, your discoveries about medicinal cannabis. And I want to take this opportunity again to invite you to take part of the special report that CECHAT is doing about the 4th anniversary of Professor Carlini's first study in Brazil.
Excellent.
Give him my regards. If you know Professor Carlini, I haven't been in touch with him because he doesn't feel well. Give him, please, my regards, and hope that he will soon recover.
Okay.
And well, finally, Stevens.
It was an honor and a pleasure to talk to you, Professor Mechoulam. Wish you all the best, and thank you for everything that you have done for the humanity. Thank you very much.
Professor, once again, this recording will be available in a couple of days with subtitles in Portuguese. So to make sure that the entire, we address most of the Brazilian and Latin American population. So once again, and for that, this is the end of our 5th edition of Cannabis Thinking Talks with Professor Rafael Mechoulam. Thanks so much. See you soon, Professor. Keep healthy.
Thank you.
Bye-bye.
Thank you. Bye-bye.
Cheers, everybody.